Thank you, Dr. Hurley. It's my pleasure today to talk about sudden sensorineural hearing loss. As Dr. Hurley mentioned, it is a medical emergency because the ramifications of a hearing loss can sometimes be long-lasting and life-changing. From an anecdotal perspective, I think there's probably an increase in the incidence of a sudden sensorineural loss during this time of the pandemic, maybe due to the ongoing viral load that we see in the community. I have, over the years in my practice, seen some inappropriate treatment and referral patterns for this particular process, and that's the main driving factor why I'm here talking to you about it today. I have no disclosures. So the objectives from today's talk, first is to identify the impact of a sudden sensorineural hearing loss. As you can imagine, the sudden change of one of your senses can be life-altering and quite anxiety-provoking, especially if you had that sense the day before. Recognize sudden sensory hearing loss in your clinical setting. Discuss the ear exam and how it applies to this process, and finally discuss appropriate treatment and referral for these patients. So before we begin, let's review the ear anatomy. So first, our external ear, which is the pinna in the ear canal, the middle ear, which is the eardrum and the ossicular chain or bones of hearing in the middle ear space, as well as the inner ear with the nerves that carry that information to the brain. So the way the ear works, sound will travel through the ear canal, vibrate the eardrum, then the bones of hearing, which sends a fluid wave into the inner ear. Within the inner ear, there's little nerve endings, which we call hair cells, that capture that fluid wave, convert that into an electrical signal, sends that message along the nerve to the brain. And it's really the inner ear that's affected for a sudden sensorineural hearing loss. So what symptoms might a patient present with when they have a sudden sensorineural loss? Most common is going to be a sudden or abrupt onset of hearing loss, usually in one ear, sometimes in both, but 95% of the time or more, it's going to be just in one ear. Often will be accompanied by ear fullness or a sense of fluid in the ear. Tinnitus or sound in the ear is going to be almost universal for these patients, and vertigo is also quite common, seen in over half the patients. Sometimes you'll get a history where there was a preceding viral or upper respiratory illness. Well, what might a patient say when they come in complaining of a sudden or having a sudden sensorineural loss? So most patients will typically say, I woke up and I can't hear, or I felt a pop in my ear and then my hearing was gone. Or it feels like I have water in my ears and it needs to pop and needs to drain. Sometimes when patients say this, it really throws off the practitioner because they're expecting to see fluid in the ear, and maybe that's where they get some tunnel vision. They're unable to think about what else might be causing this patient's symptoms. Or all of a sudden I had a loud ringing in my ear and it's hard to hear. All of these complaints can be combined with some vestibular symptoms. Oftentimes the patients will complain of vertigo or the world spinning around, they're sick, nauseous, vomiting. So there's a significant healthcare burden associated with a sudden sensorineural loss. The incidence is about 66,000 cases per year. It's likely more than that, mainly due to the patients who self-resolve over time. This is going to result in many healthcare visits, often for the initial episode, but maybe the patient's been misdiagnosed, they're seeing multiple other folks. Maybe when they do go to see the appropriate physician, they're having multiple clinic visits to treat that episode of hearing loss. Oftentimes, as I mentioned, there's comorbid dizziness and tinnitus. Dizziness, as I mentioned, is quite common, may have lifelong and long-term symptoms associated with that. So not everybody does that dizziness completely resolve. Likewise, with tinnitus, as you see in almost all patients, and this may be the predominant symptom in a lot of these folks. And we know that tinnitus can have a significant economic and psychological impact to the patient. Typically, the tinnitus will improve if we're successful in improving the patient's hearing. And that's why improving hearing in these patients is vital. What kind of problems do you see with a unilateral one-sided hearing loss? Obviously, the patient can't hear from the affected ear, so we have what's called a head shadow effect. So if my left ear is deafened, sound coming in from that left ear will be blocked by my head from getting to the right ear. So the inability to hear anything, especially with potentially dangerous sounds coming from that side, say an oncoming car if you're crossing the street. The brain is designed to have two ears, so your ability to localize sound is going to be impaired if you have hearing loss in one ear. Also, hearing and noise. The brain is used to having signal from both ears. It's able to take both that signal to help null out the background noise. If you have hearing loss in one ear, your ability to do that will be greatly reduced. Any of these symptoms will be greatly compounded in folks with pre-existing hearing loss. We do tend to see this in an older population, although it can really affect any age. But if you have pre-existing hearing loss, these problems with the unilateral hearing loss will be much worse, and generally decreasing your quality of life if you lose a sense all of a sudden. So what causes it? For the cases that are occult or we don't really know what's going on, there's a few things that we think might be causing it. First is a viral type of infection, just because some of these patients may complain of a viral type of illness prior to their hearing loss. Likewise, there's a possibility of a vascular cause, meaning a rupture of a blood vessel within the inner ear, some sort of spasm of the blood vessels going to the inner ear, or some sort of clotting mechanism as well. There's not a test to tell us if it's viral or vascular. Likewise, autoimmune conditions can sometimes cause a sudden onset of hearing loss, and these are the folks who will tend to get it in both ears, but this is quite uncommon. Also uncommon are retrocochlear lesions, acoustic neuromas, meningiomas, anything that might affect that nerve going from the inner ear to brain may cause a sudden hearing loss. However, 9 times out of the 10, when patients come in for their evaluation, we're not really sure what exactly caused that individual patient's sudden hearing loss. Now, there are some causes where the trigger is clear, noise-induced hearing loss or some sort of pressure event or barotrauma that the patient experienced. Sometimes ototoxic medications, antibiotics, chemotherapy agents, certain diuretics can cause hearing loss as well, and sometimes it occurs suddenly. So how do we evaluate a patient with a sudden hearing loss? The typical history for patients with a sudden sensorineural hearing loss is the onset of less than 3 days, although it's typically overnight or all of a sudden. There's really big 4 otologic symptoms you should ask anybody with any ear complaints. That's hearing loss, tinnitus, fullness or pressure sensation in the ear, or dizziness. Those first 3 are almost completely universal for patients presenting with a sudden loss, although dizziness is fairly common as well. You're also going to want to inquire about focal neurologic symptoms as well. You don't want to miss the patient coming in with an acute stroke with a hearing loss as well, so you definitely don't want to miss that. For the physical exam, it's really going to be focusing on the ear exam, what the ear looks like, and we'll talk about the Tuningfork Exam, which is really going to be vital, and one of my main goals of this presentation is to instruct on the tuning fork and really how important that is in your setting in evaluating these patients. Again, a neurologic exam, you don't want to miss the patient with a stroke. So in order to know what's going on with the ear, you have to know what a normal ear looks like. So this is a picture of a normal ear. As we can see around the edge, that's the ear canal. Centrally is the tympanic membrane, typically looks like looking through wax paper. The structure you see resting against the eardrum is the malleus, the first bone of hearing. Again, there's no fluid or any type of disease process going in behind the eardrum that we can tell. And so the majority of patients with a sudden sensorineural loss, this is what your ear should look like. It's going to look normal because it's not an external ear or middle ear problem. It's the inner ear, which you can't really see. The only way to see the inner ear is to image it. However, if you do have a patient with some scarring of the eardrum, so forth and so on, that does not rule out a sudden sensorineural loss. Chronic ear disease is so common. So a lot of patients walking around with some minor abnormalities of the eardrum that may be throwing you off. So you still have to consider a sudden sensorineural loss, even if your exam is slightly off. However, I do want to go over some relevant otoscopy findings to help better evaluate these patients. So first is simply a cerumen impaction. Cerumen can look any different shade of orange, yellow, brown, different moisture levels. So on the left there, that's a typical cerumen impaction, completely occluding the ear canal. That wax needs to be cleaned. On the right there, you see a picture of otitis externa. The skin of the ear canal is slightly swollen, it's red, there's debris there. Likewise, foreign bodies, anything that can go in the ear probably has dirt, rocks, toys, beads, what have you. Also, different animals and critters don't mind crawling into your ear from time to time as well. Likewise, tympanic membrane perforation can be seen. It's not too uncommon. So on the left there, it illustrates a small perforation of the eardrum. However, on the right side shows a near complete perforation of the eardrum. And this is where it gets a little bit tricky, is diagnosing otitis media. I can tell you when I was a medical student, I had a very difficult time telling you if there was fluid behind the eardrum or not. Even in my fourth year, after 2 rotations within an ENT department, I still had trouble. So it really takes some time. So I implore everybody when they're coming in, look at your patient's ears so you kind of know what normal looks like. When you see abnormal, you kind of know it when you see it. So otitis media on the left, this is a purulent, thick fluid built up behind the eardrum, but the eardrum itself is intact. On the right there, you see otitis media. However, there's a hole in the eardrum. There's drainage coming from the middle ear into the ear canal. Now, this is otitis media with effusion, so less of an acute appearing ear on the left. So you can see an air fluid level. Below that is an amber-colored effusion within the middle ear space. However, on the right side, you see the middle ear that's completely full of fluid. So if you didn't know any better, you may just assume that that's a normal ear. However, the eardrum still looks a little bit dull. I know in the textbooks we're told to look at the cone of light. However, there's a completely full middle ear with an intact cone of light. So you really can't use that with any semblance of accuracy to diagnose middle ear fluid. Likewise, you can see fungal infections. Fungal infections are common here in the valley. You can see spores and hyphae. It can be white, black, really any color. And this is our final finding. And so when you see a patient coming in with this finding, you can see the eardrum. However, there's this big patch of white against it. That is not fluid. That's not infection. That's tympanosclerosis, really scar of the eardrum. That could have occurred from previous ear infections, trauma, perhaps that individual had a tube within their eardrum previously. And so if you see a patient coming in with that exam complaining of symptoms with sudden hearing loss, you still will have to consider that in your differential. It does not necessarily mean that that patient has a middle ear problem going on at that time. So again, the other important part of the examination is your tuning fork exam. And I'm going to go over this, but those watching at home, please, you'll need to review this just to make sure you know exactly how this tuning fork exam is conducted. It's not complicated and will pay you dividends many, many times over. So the first part of the tuning fork exam is the Weber. It's what we call a lateralizing exam. So what we do is we'll get a tuning fork, and it has to be placed, or really should be placed on bone. The thinner skin area, the better. Either the mid-forehead or over the nasal bridge, over the nasal bones. You'll want to use a 512 Hertz tuning fork, okay? They're $10 on Amazon. If you do not have one of these, you need to go get one. Order one today after the conference is over. Don't use a 256 tuning fork that you use for neurologic exams. They don't work for this. Again, you want to strike this on either your knee or your elbow to get the appropriate tone, not on any piece of furniture. It doesn't hurt. When you place that tuning fork into the patient, you ask them which ear they hear it in, louder or stronger, right, left, in the middle, or they can't tell. So we say this lateralizes. So how do we interpret the finding from this test? So if the tuning fork lateralizes to the affected ear, the ear that they have hearing loss on, that would suggest a conductive loss, which would be a problem within the ear canal or the middle ear, possibly fluid or any other middle ear cause. If it goes away from the affected ear, that's more in line with what we call with a sudden hearing loss or a sensorineural hearing loss, which is what we're talking about today. So again, there's a right way to do it and a wrong way to do it. As I said, you can place it on the mid-forehead, which is easily done. You can see that demonstrated here on the left. In the textbooks, you'll see what's demonstrated on the right. This is wrong. It does not work. Don't do it. The second part of the tuning fork exam is the Rene test, and I would argue this is the most important part of the tuning fork exam, although we like to combine both the Weber and the Rene test together. Again, we're going to ask the patient which is louder, behind their ear or in front of the ear, number 1 or number 2. First, you'll place that tuning fork onto the patient's mastoid, behind the ear, the thin-skinned area right behind the ear. That will be number 1. After they hear that tone, you'll immediately move it out in front of the ear, about 2 inches away from the ear canal, with the top of the tuning fork being in series, meaning pointing in a line towards the top of the ear canal. And they'll tell you which is louder, number 1 or number 2. Again, you're going to use the same 512 hertz tuning fork. So what does that mean? If they hear it louder behind the ear than they do in front of the ear, that's consistent with the conductive loss, middle ear fluid, not a sudden hearing loss. However, in the affected ear, if it's louder in front of the ear than it is behind the ear, that's either the normal condition or it's a sudden hearing loss or a sensorineural hearing loss into that ear. Again, for the René exam, there's a correct way and an incorrect way to do it. As I mentioned, you place it behind the ear and then in front. But on the wrong section here, there's 2 things that's wrong. One is he's using the wrong tuning fork. That's a 256 hertz tuning fork. And 2, he's holding it so the tuning fork is parallel. So that sound is being jettisoned towards the ceiling of the room and not towards his ear. That's incorrect. So as I mentioned before, the René portion of the tuning fork exam is the most important. There's a 91% accuracy in determining conductive versus sensorineural loss in non-expert users. So if you only use the René test in the affected ear, you could pick up most of the sudden losses that come into your clinic. One caveat is the patient is completely deafened in the affected ear. When you do the bone conduction test, placing it behind, it may in fact cross over to the normal ear in profound losses. But of course, if you did that, they may tell you that they hear it in their other ear rather than the affected ear. So again, if you learn nothing else from today, take home these messages. So otoscopy with proper tuning fork exam, you're going to capture the lion's share of sudden hearing loss. This is going to help you guide appropriate therapy and referral. If we do this, we can reduce the morbidity associated with sudden sensorineural loss with delayed presentation, which is the main issue that we see with a sudden sensorineural hearing loss, is the delayed presentation to our clinics. When in doubt, refer to ENT. So what's the workup that you should be doing? Stroke workup if indicated. However, there's no real other workup that's indicated at that time. Labs are not indicated for a sudden hearing loss. CT scans not indicated for a sudden loss unless you're using it as a stroke workup. However, when we see the patient, we're going to do a full history physical, comprehensive audiogram, oftentimes order an MRI scan. So one of the most common misdiagnoses that we see associated with a sudden sensorineural loss is the ear infection, otitis media, ear fluid, eustachian tube dysfunction. So why is there this confusion? Well, oftentimes, the middle ear or ear infection, eustachian tube dysfunction, may be brought on by a preceding URI or sinus infections or allergies, very similar to a sudden sensorineural loss. The symptoms are nearly similar: hearing loss, fullness and pressure, perhaps a sound in the ear. Dizziness tends to be less common, but can be seen from time to time. It can also be rapid in onset. And again, otitis media is quite common, tends to be a little bit more common in children, but you can see it in adults as well. So why is this a problem? This misdiagnosis will lead to use of therapies that are just going to delay the treatment and are not going to be effective. So antibiotics, decongestants, nasal sprays, and likely an inappropriate dose of steroids. None of these treatments are going to help with sudden hearing loss. So to further illustrate this, I'm going to present 2 patients, one with an otitis media, one with a sudden sensorineural loss. You can kind of see where the confusion may lie and what we can do and how we can determine which is which. So the first patient, Harris, is a 50-year-old male, otherwise healthy, sudden onset of hearing loss, right side 1 week ago, recent head cold. Ear feels full, has sound in the ear, minimal dizziness. Julius, his counterpart, 75-year-old male, much less healthy, wheelchair-bound, multiple medical issues. Sudden onset of hearing loss in the right about a week ago. Again, recent head cold. Ear feels full, has sound in the ear. Severe vertigo, but starting to subside. So what do we see on exam? And if you ask me, I don't see a whole lot of difference between these 2 pictures. There is a difference, in fact, but from the layperson's eyes, and when I was a 4th-year medical student, if you showed me these 2 pictures, I'm not sure if I'd be able to tell you if one was normal or abnormal. So ultimately, this patient boils down to the tuning fork exam. Again, why I think this is so crucial to understand how to perform a tuning fork. So Harris, his Weber will lateralize to the affected ear, the right ear. That's what we see with the conductive hearing loss condition. Likewise, with the Rene, he heard it louder behind his ear, which is number 1, as opposed to in front of the ear, which is number 2. That, again, indicates a conductive loss. His left ear was the normal condition. So the diagnosis would be a conductive loss on the right based off the Tuningfork exam. However, Julius is Weber to the opposite ear, the left ear, the opposite side. Again, with his Rene Tuningfork exam, he heard it in the normal condition, which is louder in front of the ear than behind in the ear. So the sound conduction mechanism is normal. And so his diagnosis from his Tuningfork exam is a sensorineural loss on the right. So ultimately, Harris had the otitis media with effusion, and the Julius had a sudden sensorineural hearing loss. And so it can be a challenge to differentiate between the two. Because of the similar symptoms, sometimes the exam is not clear. So you really need to utilize not only the history, physical findings, but your Tuningfork exam as well. So how do we treat these patients? So at the primary visit, when the patient's coming in to see you, I want you to think of only one thing: steroids, steroids, steroids. This has to be a high-dose steroid. We like to treat the ear with at least 60 milligrams of prednisone daily, hopefully for at least a week, at least carry that patient over until they can be evaluated in our clinic. Prescribing a Medrol dose pack is like bringing a water gun to a forest fire. It's not going to work. If you're unsure if this is an otitis media with effusion or a sudden hearing loss, again, give steroids. It's going to help both conditions, but you have to give that patient an adequate dose of steroids in order to help them. However, if the patient has a contraindication to oral prednisone or other type of steroids, this is an emergency ENT referral because we have another treatment with an intratympanic injection of steroids that may be able to benefit that patient. Antibiotics don't help, and there's very little evidence that antivirals help. So when do you refer these patients? Anytime you suspect the patient has a sudden hearing loss. If you're unsure, refer that patient. Really, the referral should be urgent. So any patient with a sudden hearing loss should be seen as soon as possible. Same day, next day, definitely within that week. Considering the number of Valley ENT offices throughout the Valley, there's no excuse for us not to be able to see these patients within a week. So please keep that in mind. Again, when you're referring to ENT, you should state the emergent nature of the complaint. So having the patient call for a referral is inappropriate, or things like sudden onset of ear pressure, ear fullness, simply describing the patient's symptoms will delay that patient getting into the office. I would actually go as far to say you should personally follow up to ensure the patient was contacted and scheduled for an evaluation, because this is an emergency for that patient. So what do we do during the ENT visit? First, again, we're going to do a full history and physical evaluation. Again, we'll also perform Tuningfork testing. The patient will go on to have a comprehensive audiogram with a tympanogram. If we do arrive at the diagnosis of sudden hearing loss, there's a few different types of configurations that we can see over the audiogram that we'll go over. But essentially, we use 30 decibel loss over 3 consecutive frequencies. However, clinically, we use less stringent criteria. We usually combine what we see on the audiogram based with the patient's symptoms. Oftentimes, we're comparing to the other ear to see if there's been a change in their hearing. So this is one audiogram configuration. At that chart there, at the top of the chart is the normal range, and the further down you go, the worse the hearing. So the blue X's are the left ear within the normal range, and you can see the right ear has a flat loss along all frequencies, or towards a mild range. However, you can see this configuration as well, where it's more low frequencies to the left of the chart, and the higher frequencies are normal. However, you see some patients where their ear is all the way at the bottom of the chart, where they have a profound loss. So again, we're going to treat these patients with high-dose oral steroids, 60 milligrams, anywhere from 7 to 14 days, sometimes with a little taper. However, there is an alternative to oral steroids, and that's an injection of intratympanic steroids into the ear. We use this in a few different situations. One, if the patient fails oral high-dose prednisone. 2, if the patient cannot tolerate oral prednisone, brittle diabetic, or other conditions. Or in the patient, as we previously showed their audiogram, if they have a profound loss, oftentimes we'll do both at the same time, oral prednisone plus the injection of steroids. Also, we tend to order MRI scans of the inner ear. I don't think you need to order that. Allow us to order that scan because it's a particular internal auditory canal scan with or without contrast. And so basically what we're looking for is any lesion within the inner ear, retrocochlear lesion. So this MRI scan here is demonstrating an acoustic neuroma of the left ear, and sometimes these tumors present with a sudden hearing loss into the ear. So what's the prognosis for these folks coming in? So there's a category of better and worse prognosis. So you have a better prognosis if you're younger, you don't have dizziness, you have a mild or low frequency loss. All of those factors the patient has no influence over. The only thing that they can influence their prognosis is a small gap between onset and treatment. And this is where we want to make an impact from today's talk. Likewise, with worse prognosis, the older patient, those with vertigo or severe loss, those that have diabetes, hypertension, or a sloping or flat loss. And again, the only thing that patient or us as practitioners have an influence over is the potential large gap between onset and treatment. So for instance, if a patient has a hearing loss on day 1, and then I'm seeing that patient 2 to 3 months after, that ship has failed. That ship has sailed. We want to treat these patients as soon as possible. The first week or 2 weeks is really the time where we have to make an impact, and the longer we go from that point in time, the less likely we're able to help that patient with their problem. So finally, when patients come in to see us, they'll have their final audiogram about 3 months after the onset of their hearing loss. If their hearing loss is restored at that time, no further treatment is necessary. However, if the patient does have some residual hearing loss, especially if tinnitus persists, we will discuss hearing aids with that patient if feasible. However, some of these patients will have severe to profound hearing loss, and hearing aids may not be helpful to them. So we do have some other options for them. This is a pair of what we call cross aids. It basically looks like a hearing aid for both ear. It'll act like a microphone on their bad ear, route that signal over to their better ear. So it helps relieve that head shadow effect that we talked about before, where the head is blocking the sound. Likewise, there is a bone conduction implant that will vibrate the bone of the skull and route that signal from their bad side to their good side. Again, this device here is fit completely underneath the skin with that small external sound processor, that black sphere device that you see there. And more recently, the FDA has approved cochlear implantations for those who are deafened in one ear. This is the only way to restore hearing into the deafened ear. However, we want to try to avoid this if at all possible, because cochlear implants do not restore normal hearing, and if at all possible, we like to restore their hearing with medicines rather than a surgically implanted hearing device. So to leave you with a few practical points here, for sudden onset of unilateral ear symptoms, I want you to suspect a sudden hearing loss in your differential diagnosis. Please learn your ear exam, and please learn the Tuningfork exam. And if you don't have a tuning fork, please go buy one. They're $10. Treat with high-dose steroids if you know or you're unsure. And again, the referral for these patients with a sudden loss cannot wait. It's emergent nature. So I appreciate everybody's attention today for our talk.